person to whom it happened is no longer working with us. She immediately said she was not going to do any more biopsies. She quit, and is still practicing radiology, but went to a less interventional-driven practice, something that was a little bit less traumatic. So what do? Anesthesia has to be involved immediately. I mean, they're front and center because they have the selective intubation, put the catheter down the good lung to preserve that lung so you have some ventilation for the patient, and that other one that will block the blood. Thoracic surgery also gets involved. They go to the OR immediately, like stat, just travel immediately to the OR and try and find the source of bleeding and get that taken care of. And again, we had no clue that was going to happen. Sometimes we just don't know. The other patient that died, it was a similar situation. She went back to the room. Because she was DNR, nothing was done on the table for her, so she just left it in the room. Yeah, and then surgery may be needed for that particular thing. And so far as pneumothorax, it used to be that we dreaded pneumothoraces, now we dread hemorrhage. So pneumothorax is like, there's not many slides on pneumothorax. It's like, on pneumothorax, I can handle that. There's several things that you can do. You can do autologous blood patches. When I was a resident, we used to draw blood from the patient. Mm-hmm. They'd clot there while we did the procedure and inject it back into them. You can infuse normal saline along the tract, fibrin glues, collagen foam. But in the end, those will decrease the risk to some degree. The data is mixed, but we do rapid roller. So when the patient, you take the needle out, boom, on the CT table, the patient is turned over immediately. One thing that we do, I'm trying to get the nurses to, or techs to do, is really get in there immediately and roll the patient over, and then do the post-scan, because we can tell when we fluoro if there's roll them over, and we get a scan, and then put them on the bed. We tell them no talking, no laughing, no eating, nothing. I don't care if you're the funniest person on the planet, so we don't engage them in a conversation. While they're on the table, we don't engage them in conversation. We say, I'll talk to you. If you're having discomfort, then you can speak, but otherwise, just to say, oh yes, doctor, oh no, you just accept the whatever and just what. And I have a dress rehearsal before the procedure, so they know what I'm going to tell them. Mm-hmm. Tell them, when I tell you to stop breathing, just stop. So they don't say, I didn't hear you, or whatever. And so I ascertain, are they deaf? Can they hear me well? What level of voice do I need to use to make sure that they can really understand what's going on? Because that's one of the issues. Patients are polite. They want to talk back to you and say yes or no. Give them the right to not answer you. I'm just going to ignore you and do what you told me to do. And so I biopsied yesterday a physician, and it was obviously her visit. She knew I'm not supposed to talk to you, so she just lay there. It was great. She was easy to work on. And so anyway, so that's kind of what we have, what we're looking at for today. And then we're going to do a couple of code, 3 scenarios. The main thing to keep in mind is complications will happen. We see a lot because we do a lot. A CT guided biopsy has a high rate of technical success and a low rate of major complications. I think we need to keep that balance in mind. Obviously, when something bad happens, it's just traumatic. Management and prevention is key, and I think having the people and tools on board is extremely important. Risk factors, the patient, do they cough, do they have emphysema, are they frail, can they follow instructions, are they on medications, including aspirin, that can cause a problem, do they have strange anatomy, does the lesion have any cystic components, is the lesion close to a vessel, those kinds of things. Assess that ahead of time, because that bumps the patient to a different category. If a small needle can be used, use that. Even for, I know you don't do genomics here, but use that. And just be mindful of approximating vessels. And that's it for that part. Any questions?
Is there any thought about changing or looking at the anticoagulation policy for holding pre-procedure? If it's an outpatient coming in and they're on some type of anticoagulation, I know we have like your basic guidelines, but where it seems like there seems to be an increase in bleeding.
Yeah.
Is it being revised or looked at to see if maybe it should be held longer or?
Yeah, I don't think, according to, the ones that set the guidelines are the Society for Interventional Radiology, but not only them, surgeons set the guidelines also based on their experience, neurosurgeons, et cetera, et cetera. So I think that, just take this off. Right now, I don't think there's anything afoot.
Okay,
Some of the guidelines are very broad.
right.
And for example, Plavix, that's one. Now, I like to hold Plavix for 7 days. Some people go 5 days,
Mm-hmm,
but the guideline says 5 to 7 days.
yes.
My husband's an anesthesiologist, a cardiac anesthesiologist, and he trained at the MGH, and he did his fellowship at the Brigham, and right now he's at St. Elizabeth's, he's chief of cardiac anesthesiology there, and they do not, and a lot of the cardiac surgeons from the MGH are now at St. T's, and they do not do surgeries on their patients that are on Plavix if it's less than 7 days
Oh, wow.
Plavix hold. So my threshold then is based on, if they're not gonna do it and they have control of the bleeding, why am I gonna do something that's a closed box that's dangerous? Aspirin is another thing, and particularly if it's a healthy person on baby aspirin, that's one thing. But it's an older person, and we used to do it without holding the aspirin, because they'll do neurosurgery when patients are on aspirin. But now we make them stop the aspirin, and that's a 5-day hold. Non-steroidals are a 2-day hold, and then of course Coumadin and whatnot, that's a 5-day hold. And we always check the PT and INR ahead of time. But then, it's a very difficult situation, because you have to weigh the patient's, does the patient need it, and what are the complications? And just recognize that bad things happen, and you have to be ready for them. And I think doing it in a situation where you are ready for anything is the ideal.
So just, when we get these patients on the board coming in, we know that somebody has protocoled it.
Yes.
But whoever's protocoling it is not doing the procedure.
Right.
So they're, so what he or she may think is okay, maybe, whoever's performing it may feel differently.
Right.
And our radiologists, we don't have the same radiologist, or the same person doing it every day. So is there, in order to just fine tune it or make it more specific for these biopsies that have such high rates of problems afterwards, is there any way to tighten it, or should it be protocoled by the physician that's going to be doing it,
Yeah.
looking
So
out?
I just want to say again, so the rates of severe complications are low, it's just when they happen they're disastrous.
Okay.
So the rates of severe complications are low. The rate of a complication is higher, it's almost 40%. So something can happen.
Yeah.
But the rate of a severe complication is a low rate. And so far at the Brigham, I may protocol something that somebody else does. That's how it always is, because a different person is on interventional. The way that we do it, somebody's on interventional. It's just, like for instance, I came back from Israel a month ago, and I was on interventional a couple of days later, and I get downstairs, I'm like, who accepted this case? Why am I doing this case?
Yeah.
But it was an interesting situation. It was a case that needed an anesthesiologist, but they didn't have it. So the nurse picked up when the patient came in that this patient is an anesthesiology consult. And so by the time I got the anesthesiologist, because we have, as I mentioned, anesthesia are allotted to us.
Right.
So he was there, and what ended up happening, the referring physician ordered, and you have to understand how much pressure we're under by referring physicians.
Absolutely.
So they had ordered a lung biopsy as well as a kidney biopsy for the same day. The issue is that the kidney biopsy was to be done prone and the lung biopsy supine. The kidney biopsy was going before with anesthesia, the lung was to be without. Here's a supine patient who's had sedation, they're going to aspirate. So we said, well, wait a minute, we can't do that. So anesthesiology came in, they said, we're not going to let you guys do that. You pick one, and let me know what you're going to do. He's standing there. I go, we can do this without anesthesia. Let's go first. So, because I know that when they got the kidney, it's going to take forever. So I don't want to be late. That was my motivation. I don't want to be late. So we went first, and they ended up canceling the kidney, bringing the kidney back later. Because, again, when a referring physician refers a patient, they don't recognize our limitations, and some radiologists are very intimidated by the referring physicians. I'm like, wait a minute, I went to medical school too. I'm going to make a decision about whether or not we can do this or not, and if it's safe or not. We also rely on the nurses to pick up things that we may miss, like the need for an anesthesia consult. This happened to be yesterday. I get down there, and again, I had been in France. I came back. I don't travel every week. It just happens to be multiple travels. I come back. Here's this biopsy for me. The nurse said, "This is a difficult intubation." I said, "We're not going to be intubating the patient." She said, "Yes, but this patient has a high risk of getting pulmonary hemorrhage bowel." She knew, and the patient did have a little hemorrhage. Interesting enough. Anyway, so she insisted we get an anesthesia consult, and so we did. Got the anesthesia consult. And he says, okay, we're not going to intubate this patient. I'm going to be around the corners, you know. And fortunately, the patient has limited hemorrhage, and we didn't need to intubate the patient. But so nurses oftentimes pick up that we miss because we have tunnel vision because we're very busy. We're reading like 140 CT scans a day. I finished doing my biopsies, like yesterday. I had to go back upstairs and read 107 plain films. So we're just like running all day long. It's a crazy day. So we rely on the nurses. That's why I said my first thing was we rely on nurses to get us out of trouble. So they pick it up, we're like going, praise the Lord, what shall I do next? And we just do what they tell us to do. And so we depend on extra eyes to make sure that we're not messing up and the patient is safe. So I think when we have all those eyes, it works fine. Yeah. So, but anyway. Are we going to do the mock code here or at the scanner?
So I don't think we have the people that we need involved for the mock code today.
Oh, we don't?
No.
Okay, that's too bad. I had some fun cases. All right, well, no worries.
Can we talk through a case?
Okay, we can talk
Without-
about
We
this.
have
Are there
the
any
equipment
texts?
too. Yeah.
Yeah, is it text nurses?
Text, okay.
We're not
One
divided.
thing I was going to say, I was so busy yesterday, I was supposed to email Rakesh back, and one of the most important things in a successful management of a complication is using tools that we're used to using. And so, Brian, I love that you sent me an email with all that wonderful stuff, but we don't use that stuff.
I think
And
That
so-
came from Rose. Watch.
No, the pneumothorax kit came from
The
from
pneumothorax.
Rakesh.
Okay, got it. Okay.
Yes, so we don't use that stuff.
Okay.
I was like, what is this?
Got
I
it.
said, Eric, do you use this over there? He goes, I don't use that. So I did a photo of the ones that we use so that we would kind of get on the same page
Sure.
of what we do. Okay, so the first case, we just pretend it's a CT scanning table. I'll be radiologist and patient both. So I'm going to go into I'm going to be a radiologist first, finish the biopsy, da-da-da-da. So this is a 67-year-old male. And the nurses and techs are moving the patient over. I finished my biopsy. I look at the CT scan, everything looks fine. The patient had a little bit of hemorrhage around the needle, but no big deal. The patient is moving over to the gurney, and he tells, you guys are getting him onto gurney, and he says, I feel kind of funny. I have some chest pain. What's your differential? I'm standing outside because because we're putting the computer or
Call you back.
Yeah, I can put them on the table.
Yeah, I have
And
to
then-
rescan them.
what's the differential?
Air.
Pneumo.
In the line.
Air embolism, okay? Yeah, so you put him on the table, and so several things. Obviously, you can feel the front of his chest. You can have a big pneumothorax. Probably unlikely because when we just did the scan, he didn't have a pneumothorax. Although there's a delayed pneumothorax. There's an increased risk of delayed pneumothorax. No pneumothorax, so put him on the table, and he does have air in his left atrium. So what are you going to do then?
Call anesthesia.
for air embolism?
I don't know.
Yeah,
Position.
no anesthesia, but you want,
Position.
okay, so roll him onto his left
Roll
side,
him
and then
onto
what
his
else do you
left
wanna do?
Yeah.
You wanna get in touch with somebody who can get that hyperbaric chamber,
Okay, but before that,
100% O2.
100% O2, 100% O2, put him on his left side down and call a code. I would call a code at that point, any hands on deck. And after you call a code, we would probably call anesthesia, because they can intubate the patient if we need and really deliver oxygen, and then get the patient transferred to hyperbaric oxygen, okay? So remember, 100% oxygen through a high flow mask, and then, okay, good.
So in our situation where we don't have hyperbaric chamber
Yes. So
here,
you will need to get in an ambulance and
get them over
get
to,
them over, call me, take a patient with air embolism, this is the situation, da, 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 da.
The
Okay.
General is the only hyperbaric in Boston?
I think that's the only hyperbaric in Boston,
Mass
I thought Mass
Pioneer.
Pioneer,
that general area.
but it's
Okay.
there, it's theirs.
Yeah. So that's, and, you know,
Okay.
it's really interesting that, yeah, so that's the main thing, so, but the patient said the chest pain, don't, so, I've seen this happen. They'll say, oh, so where do you feel it, get them on the table, don't ask questions, just boom back at the table, and the tech just immediately just scan the patient quickly. You know, whatever parameters, just scan the patient quickly. And the most useful will be bringing it up in lung windows, because small amounts of air will show better on the lung windows. So just do lung windows for you guys, but for the rest of them, just do that. Okay, second scenario. The patient, now where's your recovery room relative to the biopsy suite?
Normally they go to PACU, which is down at the hallway.
Oh, no, so
Yeah.
they get there and they kind of wheel them down to that,
Right.
okay. So the patient is over there in the, in your suite. The patient finished the biopsy. He's over there and he's talking to you, the nurses now, and he says, I'm short of breath, boy, I'm really not feeling very well. I have a lot of pain here on this side where the doctor had the needle. As you talk to him, his SATs are deteriorating, and you notice that he's just really struggling to breathe. What do you do? What's your differential, and what are you gonna do?
Pneumothorax.
Hemothorax.
Pneumothorax,
oxygen,
hemothorax?
and
Okay,
Back to the scan again.
okay,
Call
Meantime,
anesthesia.
Chest x-ray?
okay. He begins to, as you're calling for the tech to come do the chest x-ray, he begins to have hemoptysis,
Anesthesia.
okay? Anesthesia.
Suction.
You call immediately for
Oxygen.
anesthesia.
So we call it code.
So
an
And
intubation.
in your location, you'll call a code
Yeah.
and make sure they send an anesthesiologist.
So I just have a
They'll
question,
be
so
there.
you're talking about your little PACU area or the?
No,
at the PACU.
Big
So are they
PACU.
aware of any of this?
No, but they'll be
Well,
on
they
our list now.
anesthesia there all the time too, so they know to call the code if something not going well.
Yeah.
Because that's what they do over there, they recovery all
Yeah.
kind of surgery, so all the nurse there is all like, you know,
Yeah.
ICU nurse
Okay.
experience.
And if they just have a shortness of breath, get an x-ray rolling, get some sort on the way. But if while that x-ray is on the way, they begin to have hemoptysis, you have your diagnosis. And then you need to call anesthesia, call a code to get them there. And they need to come with we tell them to come with. Make sure they come with selective endotracheal tube for selective intubation. So when you call, you need to be very specific. Say, my patient is having hemoptysis. Make sure the anesthesiologist is equipped with a selective
So
intubation
see,
tube.
for us, if we call the code, we push the button and they're there, so we don't really have a
Okay.
chance to communicate with them,
Oh,
to
is that
tell them
right?
what to bring to us.
I see, so they don't even know, yeah,
But we have it in the
No,
CT
but-
room now, the equipment that we would.
right, because the other thing is they won't know which patient is coding and what to bring.
Right.
Right, so that was a little bit of the stocked
Because
room, when you
our-
mentioned a stocked room, so what does the stocked room look like?
Yeah.
Because we have some materials from anesthesia, but yesterday Jess and I watched, or a couple of days ago, we watched the Easy Blocker. So we're talking about using a bronchoscope to put the Easy Blocker in. So that
I don't know what
brings,
that
so,
is.
the Easy Blocker is a balloon to tamponade one of the lungs that are bleeding. So, but it could go through an endotracheal tube, but the video starts out talking about a bronchoscope, so it's really a Dr. Schaff question. But, so that's to follow
Yeah,
up with
because I
him,
don't-
so
I
that
don't know
again,
enough
the
about
right
that.
equipment in the right place.
Yeah, I don't know about that, because what you would want to do is intubate the good lung to make sure you get
Yeah.
aeration.
Right, and that's what this provides,
yeah.
but
That's that blocker thing you're talking about?
that's the blocker.
I'm an anesthesiologist, this is just all interesting material to me.
Got it.
Right, so it's your well-stocked room, and then it's anesthesia's well-stocked room, and
Yeah.
then it's, you know,
So I would
My
talk to
was stuff.
anesthesiology, just make sure that, because again,
right,
you're safe and you're doing your way of doing it. So the point is that the bleeding lung needs to be quarantined and the good lung needs to be aerated.
mm-hmm,
So control and quarantine, that's what needs to happen to the bad lung. So whatever it is, while maintaining aeration of the good lung. And you don't want any spillover whatsoever into the good lung.
Right.
So whatever it is anesthesia thinks they need. At the Brigham we use like selective intubation,
mm-hmm,
is what we use.
yeah, so
And
we
that-
just
that-
need to
that is-
talk to them
That is
and,
on our code cot in the radiology room, it's on a code cot, it's in the recovery room, it's everywhere. And the anesthesiologist always had it in his pocket. He showed up yesterday, a couple of days ago he showed up with the tube, and Mark Hammer, my colleague, was hilarious. He's like, "Where you going with that thing? I think my patient's gonna be fine." It was a very funny conversation, he said. But anyway, they come ready, as soon as they hear code and radiologist like, "We've got it," it's like, "That's not what we need."
So maybe because we do huddle with our radiologists every day in the morning when we have a lung biopsy, and they know how close it is to the vessel.
Yeah.
And maybe we mention to them, should be FYI anesthesia, that we're gonna have lung biopsy in
Yeah.
CT, because we only have one procedure
Yeah.
CT room, and
Yeah.
that way,
Well, that was the question I just got asked. by
Yeah.
staff, and
that's where when the
He
code call,
He
it
didn't
show
seem to-
location
He
to them.
seems to want to be
Yeah.
engaged. I was like, "No worries, you guys, the nurses will get you out of your cage."
I do think we should have a follow-up with Dr. Schaff as part of that mock code, though.
Yeah.
Yeah,
So.
exactly.
He couldn't
because
stay for the whole thing, so that's why we have to.
yeah, exactly. But I think that really, when you guys do your huddles,
Mm-hmm.
it's just radiology people in the room. It's not anybody else. Can you see? Can the OR people see the radiology schedule and vice versa? See, at the Brigham we can see each other's schedules.
Only they have to go, the anesthesia can go in and see our schedule, but they have to actually choose
it.
it. Yeah, choose to go
Okay.
in.
Yeah, because anesthesiology just looks at our schedule every day. They just walk through. It's like,
That's so
I
nice.
said, "What are you doing?" I said, "Do we?" Yep.
When the
We're
patient goes
good.
to the PACU from CT, and if they were to start developing some type of minor complication
on
or
board.
moderate, they're calling the radiologist who did the procedure, correct?
For notifying MD,
Yeah,
yes.
Yeah,
Mhm.
and then the radiologist is
We'll
going
go
over
there,
there.
yeah.
Yes, who may or may not be able to help. It's always so funny. This is the biggest joke in our reading room.
Mhm.
They go, you hear code blue, da da da. So we get up, and we go, we hope a real doctor's on their way.
But
Yeah, I
you're
think we
far,
didn't have a radiologist
Right?
respond
you're
yesterday for
far
our mock
though,
code.
your offices are far.
Yeah, we're way away from.
Well, the
yeah.
same thing here too, I mean,
Yeah,
the
but-
chest person's on the fourth floor.
Yeah,
So
but
it's-
we're downstairs for the biopsy procedure, and then the abdominal reading room is right there
Right
next to the
there,
biopsy, so
yeah.
there's always a radiologist running around there, so, believe me, I'm worthless when it comes to any of those
Yeah.
things, I don't know,
Well,
intubate, so,
and then abdomen would be involved.
yeah, if
for
they
a
need to.
neuro.
Yeah, so we put in our own chest tubes now, we do our own chest
Okay.
tubes. I've got one more scenario, but the other thing is, do you guys have the one-step centesis, non-valve one-step
Mhm.
centesis catheters?
Yep.
We like to use those, so we can
Okay.
keep on moving with those.
And usually like a 7 or a 10 for
Um,
length.
The 7,
Okay.
yeah, the 7.
Have
Unless it's some really,
have
really
you been
big,
in the
huge
CT
person.
room?
I've been in the CT room, yes, but I haven't recently since.
Okay,
uh,
yeah, 'cause, I'm
We'll take
thinking
a tour.
maybe
Yeah,
right
that's
after
what I'm
this,
saying.
you
Yeah,
kind of go through where stuff is.
That sounds good.
Great. I
Perfect.
had worked with Rashna before.
Yeah.
So
Yeah.
that'd be great.
Okay, good, then we can do that. And then the last case, patient has shortness of breath. And there's a real life case that happened to us. The patient is in a recovery room an hour after the biopsy, shortness of breath, and they drop their blood pressure. What's the diagnosis? They've been there an hour in recovery, they've got another 2 hours, they got their first film, nothing, and they're waiting for their second film in 2 hours, PA not showing 2 hours. They're sitting there and get short of breath and the blood pressure drops.
Slow growing pneumo?
Bleeding out?
Yeah.
Yeah.
Bleeding.
Delayed
Are they
pneumothorax.
tachycardic?
So they called, the nurses down there in the unit called Mark Hammer, who was upstairs in the reading room, and says, your patient is really short of breath. Mark jumped up and ran like the dickens to get there, and long before he got there, there's an anesthesiologist standing there putting a chest tube in place. I mean, that's how fortunate we are, actually.
Wow.
And the patient had a huge tension pneumo with cardiac tamponade. Had the anesthesiologist not been there, the patient would have died. But the PACU knew to call anesthesia. So we have a unique situation. We don't call a code blue because the patient's talking, we call anesthesia. And boom, they were there, and he listened, boom, and that tube was in. Mark came running out of breath, the tube was already in the patient. You know, so it was
What
a
would we
real,
do, our body doc, but the body doc could be in a procedure.
that's the problem.
Right.
And
There's
that's
nobody
the
always
problem.
here.
Yeah, that's the issue. So you just have to just weigh, you know, use what you have, what tools you have. Obviously anesthesiology can come and do it. I'm told that the pulmonologist here can put in chest tubes, because that big of a chest tube we don't put in. It's a big tube at that point, and we don't have to fuss around with, you know, whatever it is that we're gonna do. There's plug it in, you're done. We have to do this, that, and the other.
We usually have Dr. Kwa that we normally will call him and FYI
Is he, I hear he's
him.
not always here
He's
though.
not
Not
here every
always, but
day.
just,
Right.
yeah, but we normally, like, we used to, not the best practice anymore for some reason, but when I just started here 2 years ago, we used to, in any case, we page him just in case he's in-house to
Yeah.
just FYI.
So
him.
you need to
Yeah, that's part of the
identify,
rule.
and what we usually do, we identify, in all cases anesthesia, someone that is gonna be there regularly if there is a lung biopsy that's going to be there that will be able to cover you. I think that's the first thing. Putting the people in place that will be able to cover you should something happen.
If something happened,
So when we're doing our timeout, we'd make sure we have all those pieces in place.
Exactly.
Yeah.
Exactly. Just make sure that that's, it just, and you know, again, severe complications are rare, but complications are common. You know, so just have everything in place ready to roll so that you know what's happening. But that was a dramatic case, and anesthesiologist saved the patient's life and Mark's butt, and so it was really, you guys know Mark. He's an amazing
Oh,
human
he
being.
is. I just feel like he just threw the dart on the thing and done.
He is
So good,
amazing.
yeah,
He
so
is so amazing. Yeah, he's just one of my favorite people on the planet. We get along great. I like to give him a hug. I call him the hammer. But he responds to the hammer. Anyway, so those are the scenarios that would, you know, need you to kind of get thinking about how serious is this procedure? What do I need to have done? Something super bad may not happen, but I'm prepared, I'm ready, I'm comfortable, and I think that's the main thing, feeling comfortable and ready for anything bad that could possibly happen.
But I think that's the key from today is to identify, you know, your backup, who you
Right,
have, if
exactly.
something, you know, happen.
Exactly.
Yeah.
People need to be in place, assess the patient,
Yeah.
utilize all the people on the team, the nurses, the techs. You guys know things in different ways that we don't know. And sometimes we're just so preoccupied with our huge, long list. We're reading almost 400 cases a day. And we know what the list, so we're just like going, oh. And so we're burdened with this, that, and the other. So you guys are more fresh, and so you guys can really be
We're working pretty hard here too.
No, I know, but you know, it's
Just
just,
thinking
it's really, you know, because, but I mean, the radiologists are over there, we're doing our thing, but yeah.
Yeah.
But you guys have knowledge that we don't have. And so we just rely on everybody in the room, and the team, to help it go smoothly. Yes?
Question. So when you say chest tube, this is another conversation Jessica and I had. Do we need chest, when you say chest tube, I
Okay.
think of the big mother
Yeah.
chest tube
So the
that I would put
anesthesiologist
in.
No, for
So-
tension pneumo, you need a big tube, you need to get the air
Right,
out
so
now.
we need big
So
tubes.
you don't necessarily,
So-
the anesthesiologist came with the tube.
Well, no, we probably need the big tubes here, because again, anesthesia is,
Yeah.
you
But
know,
in the
again,
room, you
looking
won't
at
probably need
location,
it.
location, and,
Yeah, so in the room you probably won't need it. So what we use, and I have a thing here, and this is, I'm just gonna give you a little list, a little shopping list.
perfect.
So that pneumothorax kit has a whole bunch of stuff we do not use. and I took a bunch of pictures, and Brian, I was gonna send those to you, and I did not. So we do not suture in our tubes, we use, and I'll send this to you so you can get that. It's called this plastic gizmo, have you seen this? Yeah, that's what we use.
Can I see? Oh, yeah. we have
Safe.
those. Yeah.
Yeah, so so that is what we need, and it's called Stayfix.
Yeah.
Stayfix. And then, a .035 guide wire, so some people use trocar technique for their, putting in, chest, pigtail catheters, should say chest tube tubes,
Mm-hmm.
and I use the Celiger technique.
Sure.
And the reason I use the Celiger technique, sometimes the pneumothorax is big, but not big enough to trocar in. And the last thing I wanna do is get the heart. I wanna keep my license. So I prefer to use a guide wire. So we have that, and then so we need dilators, and the biggest tube we put in is an 8 French. So that huge kit, you probably pay a lot of, it's sort of like buying packaged vegetables, it's more expensive than buying the, a head of broccoli, a head of this, that, and the other, and when this little thing is more expensive. So you might be better economically to buy just what we need, not buy a whole kit that has stuff we don't even use. You sent me the picture of the
And
kit.
this is what you don't. You
Yeah,
do
we
not
don't
use
use that.
Alright, perfect, so we do
Yeah,
everything else.
we don't use that. So we use either straight guide wire or a little guide of .035.
And like an 80 length, 80 centimeter length.
This is 80 centimeters, I think. This is 80 centimeters, yep, and 80 centimeters. It's a .035 and plats.
Perfect, that's
Extra
exactly,
stiff.
that's
You
exactly
have
what
that?
we have.
Good,
Yep.
perfect for that. And then